Hey Doc, it's Nick. This is a case you wanted to plan together for our patient LT. So this was a case, patient's been a dentalist for a while, had a sinus lift done that didn't have 100% conversion, but we definitely have some, you can see some new bone right here, which is definitely helping the cause. So patient wants 2 implants here, definitely a case we can do together. So let me just kind of walk through how I'm planning this. So I put 2 implants in, and typically what I'll do is I'll come over to this axial view here, and then I'm going to measure the available space I have for the implant. So I have about 21 millimeters. Now we know that the minimum distance between an implant and a tooth is 1.5. So we have 1.5 and 1.5, and then the minimum distance between 2 implants is 3 millimeters. That's if you have an ideal spacing between the teeth, but it's rare that we do. It's often close, but not always the case. So I start with this exercise in my head, and I just take out a piece of paper and I start drawing out what would be the ideal implant diameters, distance between the 2 implants, and distance from the tooth. So if we have 21 here, let's just subtract 3 for between the implants. Now we're down to 18. Another 3 for the 2 1.5s. Now we're down to 15. That gives us 2 implants that can share 15 millimeters. Obviously, that's too much. So let's just say 3, 3, and 3. That's 9. So 3 millimeters from the tooth, 3 millimeters from the adjacent implant. I don't like to go more than 3 from each implant. It's a better emergence profile prosthetically if you keep them somewhat close. I would rather use the likely papilla that's between a natural tooth, so I'm more likely to go farther from the 1.5 minimum than I am the 3 millimeter minimum between the 2 implants. So 3, 3, 3 is 9. 9, that leaves us down to 12. So we could place 2 6s. So as you can see here, we're really looking at ideally placing 2 large implants. So now I have some idea on the spacing requirements, but now I'm going to come over and look at the buccal lingual width, because I might not have 6 millimeters. I might not even have 4. So let's start with this implant here. As you can see, we fortunately have a pretty good buccal lingual dimension here to play around with. So I want to do something like this. Right now we have a 10 millimeter long implant, and I'm going to go to a 5. We could probably go to 6, but I don't like going too wide. I want some cancellous bone around the head of the implant. That's preference. So if we have a 5 millimeter wide implant, now we use BioHorizons, they don't have a 5 millimeter implant, they have a 5.7, but I'm just doing an exercise here to see where we land. Then I come over here and I say, all right, do I have any width here for the implant? We'll talk about this in a moment. But the width here, I have quite a bit. So I'm actually going to go, I want to go 5.5 here. It'll actually be a 5.7. And then I want to look up here and just get a general sense of where they are in the ridge. Let's come over here. Let's bring that over a little bit. Trying to get the axial slice to behave. All right, so that's better there. So we don't have as much buccal lingual width here as we do with this site here. So we'll call this 3 and 4. So that's 5. I'm going to go 4.5 because we have a 4.6 millimeter implant with BioHorizon. I like that right there. So we can do it'll be a 4.6 by 10.5, which is perfect. So we get a nice implant here, and then we're looking at this implant here. This is a 5.5, again 5.7 by 9. We have in the BioHorizon line 5.7 by 9, 10.5, and I think 7 is as low as it goes. But I think we can definitely get a 5.7 by 9 here very predictably. So here's the grafted bone, or the amount of grafted bone that's stayed. The original provider definitely had a full volume of bone. Unfortunately, sometimes sinus grafts don't take 100%. We're left with what we're left with. The good news is doing a lateral augmentation here is relatively straightforward. So essentially, we're just going to do the osteotomy until we feel like we're starting to encroach upon the bone slash Schneiderian membrane interface. And then we're going to either use the Densah. I don't know if there's enough grafted bone here to stay away from the Densah Burs, or we're going to actually add some bone and do an internal lift and place the implant at the same time. You and I can walk through that when we do it in person. But in a nutshell, these are the implant positions that I would be happy with. I would probably rotate this just a little bit, kind of in this direction, and this one in this direction. Whether or not we splint these, we can talk about when we're approaching the prosthetic phase of things. But in a nutshell, I think this is relatively straightforward. We're going to have to do a little internal lift. We're not going to charge the patient. She's already been charged for the sinus lift. This will be easy enough to do, but let's do it together and plan what to expect to feel when you get to that certain depth where you're actually going to be running up against the grafted bone. There's predictable ways to do this without much of an issue. I'm not sure if I love this angle here in relation to this tooth, but I don't think this tooth is really a long-term play. So I don't think I'm going to let the angle of this implant be influenced by this tooth to any great degree. Let's go ahead and take a look at that tooth from a axial perspective. Just trying to get a sense of the bone around the tooth. So looking at this right here, you can see here there's what looks like probably some vertical bone loss. We often see vertical bone loss when molars tilt mesially, when you're missing a tooth in front of it. Depending upon the occlusion, the tooth will tilt and you'll see a lot of vertical bone loss. That's most likely what that is. So let's come over to here. That's what we're seeing right here. So that area of radiolucency, this slice right here is this axial view. And as you can see, the line comes through this zone right here where there's vertical bone loss, oblique bone loss. It's a little bit misleading. It's just due to the fact that this patient has a tilted tooth. But I see a little bit of periapical radiolucency here. Long story short, I'm not sure how much this tooth is going to survive. So placing the implant with a strong influence from this tooth is probably something we want to avoid. What I would say we do is we actually place this exactly where we want it, and then do an enamelplasty when you go and you restore this tooth, which is an important point, that enamelplasty of teeth adjacent to implant restorations is actually a very favorable thing to do. I liken this to creation of guide planes when we do partial dentures. Because of the path of draw issues of implants being very precise, so the internal components requiring a very specific path of draw, especially with a screw retained restoration, it's important to create a nice path of draw. We often will enamelplasty the adjacent teeth accordingly. We're going to want to do that anyways here. So I'm going to err on the side of actually distalizing this implant a little bit, knowing that one, we have the ability to enamelplasty, and two, the tooth has probably seen better days. The vertical height of these two teeth, obviously we can modify intraorally. We can use the Densah here because of the fact this is not grafted bone. Again, we do not want to use osteodensification in previously grafted bone unless we are confident there's been 100% turnover. Topic for another day, but in general, we're getting to sockets and ridge preservations and sinus lifts in a time window that likely incorporates a lot of leftover graft material. It might be turned over, but not turned over to the degree that we can start densifying. So that's pretty much it. I think that looks good. I will save this like so. If you want to take another look at it, make sure that our angles are coming through the anticipated occlusal tables. Something you can do is enable clipping right here, do axial, And you can look like this. And then you can control how much you're actually seeing here. So this gives me a sense of where the axial inclination of the implant is going to oppose the opposing dentition. Ideally, we're opposing the dentition in the intended opposing structure of the tooth. So here we want to contact the buccal cusp with these lower molars if the patient has proper occlusion. It looks like we're pretty close. We could probably do a little bit of this. You know, you can also look at this blue dot right here. We want that to hit the buccal cusp. That's what I was talking about there. All right, so something like that. And then let's dial this back a smidge. Is it important that these are parallel? Not really. Are they in the positions that we want based on a prosthetic perspective? That's really what our goal is here. It's a little bit towards the buccal, so I'm actually going to bring this just a smidge this way. Remember, the soft tissue and the bone around an implant is what determines the long-term success of the implant. Because we have very thick keratinized tissue that is 100% immobile on the palate, I don't mind cheating the implant towards the palate because we have that very thick tissue. In general, just like teeth, you see more buccal recession than we do palatal recession on the upper arch. So I would rather have a little bit of bone here than I would over here. So you can see I'm erring on that side. The axial inclination is still hitting the opposing buccal cusp tip. And I think this just looks a little bit better from this view here. Now this guy doesn't look as good. So there's my dot. I really need this to be hitting the buccal cusp tip, so I'm going to go ahead and swing this over like so. This inclination I like. And let's lastly measure this distance here. It's a little, it's okay. I'm actually going to keep this one here. I like how distal it is, even though it looks close to this tooth. We talked about why I'm okay with that, but I'm actually going to take this implant. Let's see how far off we are here. And just slightly bring that back. And the reason for this is I'm okay with more space here because the papilla that's going to live right here is going to be a higher grade papilla because of the fact we have a natural tooth abutting it. In between the two teeth, I didn't want to increase that space because we don't have a natural tooth that supports the papilla here. The papilla here is going to be supported by the restorations. So the closer we can get these to 3 millimeters, the better. So I'm good with that. All right. I think everything looks good. If you have any questions, let me know. But this is my recommended implant position for this case. Take care.